appreciate the opportunity to talk about the rapid response team that SAGES formed back last spring when COVID first became such a large part of our reality. And if I can give you a few minutes background on what this organization did and the challenges that it had and the things we were able to accomplish and the lessons learned from that whole period. So what is a rapid response team? If you give the clinical answer of what a rapid response team is, it's a group of clinicians that can be called upon at any time to provide expertise at the bedside of a patient whose condition is deteriorating. The military answer to that would be an armed military unit capable of rapidly responding to developing situations, typically to assist allied units in need of such assistance. I want to make the argument to you that I think this group served both purposes, and I don't think that's an outrageous statement to make. We certainly attacked the clinical element of this, and the information that came at us so quickly and in such scarcity early on was a challenge to deal with. But equally, I think we all felt like we were at war, that this virus was affecting our patients, our livelihoods, our practice, everything that was part of us. And so I would say that this group responded in both ways. And we really did have, if the definition of war is that you're trying to support and defend the health of and the success and the viability of the people whose charge is in your care, and you have a personal stake where your health is at risk, I think that counts. And so while SAGES is closing in, it's 40 years, we really had our first SAGES wartime presidents, and Dr. Pryor was the first. She was finishing up her presidential year when this landed on this organization and on her plate, and I'm going to go through some detail of how her reaction to this was so instrumental to the response. And then Dr. Aspen, of course, his entire year was essentially dedicated to the central part of this in the SAGES mission. So it started early last March with a set of emails, and the QRS committee was tasked to give a response that discussed elements of safety and recommendations for surgeons and for the membership during the pandemic. And Debbie Keller and Dina Spaniolos, who was also co-chair at that time, I highlighted this to show you how rapid that response was, that literally within an hour or two, we had those recommendations put down, edited, and sent back. And then we started to get questions. I put a sample question of what was sent to us. Is there any added danger to performing laparoscopy versus laparotomy in a known COVID-positive patient? This was just one of many questions that the committee that we were being asked to address. And so Erin Schwartz, who was our administrator, said, hi, Dr. Pryor, Dr. Dort, should we get a quick response team from QOS? Dr. Pryor said, yes, please, and it was born. And so the people up on the stage were the early recruited members of the rapid response team: Sean Suda, Rob Lim, Kevin Wasco, Dean McCamey, Eugene Cho, and then the two co-chairs of the QS committee, Deb Keller and Dina Spaniolos. And their representative committees were tasked to respond to the clinical and practice and patient care questions that were coming at us with incredible rapid fire based on the expertise of that committee. And I just can't speak highly enough of the people on this page and the amount of time and energy and effort that they put into the research that was required to make sure we were telling our surgeons best practices related to the pandemic, the latest information, the things that we're going to keep them safe, their patients safe, their staff safe through very unknown times. But there were challenges. There were challenges to doing that. First of all, the disease was new, sort of. We had viruses that got the national attention and that we had to respond to in small pieces, but nothing of the magnitude that we saw. You heard a little bit from Dr. Silla this morning. You can hear a little bit from Dr. Keller. We just in our lifetimes had not seen anything that was like this. So in making recommendations early on, we had to go to historic data. How did our other viruses behave in smoke plume, and what were the safety records based on how other transmission and surgical space elements, and we really were collecting a large amount of information in a very short period of time and having to make recommendations on that. Misinformation. I think, you know, where information is scarce, rumor fills the void. And that was very much in play where some of the misinformation flying around this virus was more virulent than the virus itself. And we had to weed through what was actual science and what was real data and make recommendations based on that. We had a time mandate. You saw Dr. Silla's numbers, and you've seen all the numbers over the past year that the daily casualty counts were just staggering, and every day was a new challenge and new horror stories. And so the significance of the time mandate that was required to get this information not only researched, agreed on best practice, and put out to the membership for safety reasons. Some unpopular recommendations, which was difficult. Telling someone to shut down their whole practice, to put off care of patients that they couldn't operate, that's a difficult thing to tell people that they have to do. And then adversely affecting patient care. If we're telling patients, we know you have cancer, but we're not going to be able to put you in an operating room for a window of time, that's a big responsibility to take. But then the positives, and there's just not enough time to go through what came out of that, but we worked fast and furiously, and we started to put through the website, through other mechanisms that I'll show you, answers to the basic recommendations. You'll see updates on those first two lines. We were constantly updating as we got new information and best practices. We had to talk about everything from the smoke plume and the safety of that, to teaching people how to run a ventilator when that was not their skill set or their practice for a long period of time. We had to talk to them about how to manage patients in different clinical realms, and down to PPE strategies for themselves and their staff. You saw Dr. Silla mentioned earlier, we also were partnering with other societies and through global surgical teams and international surgical societies, and putting out best practices and getting stories from the field and how they handled situations. And then I obviously don't expect you to read this, but the long list of not only the best practices, but links to other societies and who was doing this best, the AAST's recommendations for surgical care and the Society of Critical Care Medicine, and you can read along the list. We tried to get links to the content expertise of the societies that provided it, and that was all given out to our membership through the website and through communications. We published through our journal. We put out what those recommendations were, we put them out early, and we revised them as necessary. We ran a series of webinars, and by this point that the group of people on that screen that I showed you grew rapidly, and this really was a multi-committee, multi-individual effort of a monumental proportion that was just so inspiring to see. And our first webinar we ran in early April, and you can see the topics that we covered and the personnel who were willing to dedicate their time and expertise. We followed up a week later with topics we had not covered that we were asked about and we wanted to give information about. We discussed as we proceeded through that pathway, coming back into the operating room and the best practices and safety mechanisms and troubleshooting and all of the questions that we were getting about what does surgical care look like now that had changed so radically in just a few weeks' time. We ran a webinar on focusing just on our surgeons. It was so heavily impacting us personally, despite all of the things in discussing PPE and taking care of patients and working out of scope of practice or working through incredibly stressful times. We had our own families and ourselves and our practices to worry about, and we wanted to make sure that our goals were aimed at the surgeon survivability as well as wellness. This was a question for the SAGES Rapid Response Team, and I pointed out because it was sent in April of this year. So after the voluminous amounts of information that you saw through the website, the webinars, and I don't have the exact numbers for you, but the number of hits that we got for that information on the website is a SAGES record by magnitude order of clicks that people went for that information, and we were able to get that and distribute it so widely. But it's ongoing. That committee is not shut down. Mercifully, it did not have to work as diligently recently as it has had to work in the spring of 2020, but we continue to get questions because this virus and the pandemic continues to evolve. And we have a lot of lessons learned from how things came out early. For every 10 answers we get 100 new questions, and SAGES and the group effort of these committees and these individuals will continue wherever the rest of it takes us. The one person I didn't mention is Erin Schwartz. She was unable to be at the meeting, but she is the administrator for not only our committee, but for the rapid response team. And she ran all the communications back and forth to the team, and I really just have to make special mention and give credit to her tireless efforts as well. That's a Delta sign. I think you know why it's there. I didn't put the Lambda sign up yet, so I'm trying to be optimistic. But the beat goes on. We're all still, I took my mask off just to talk, to be able to be understood, but we're all walking around wearing masks, and we have colleagues walking through the halls telling us that they've shut down their operations again. So this story is not yet finished, and we will continue to do as an organization, as a task force, as a group of committees and individuals and members. We'll continue to fight the good fight. We'll continue to put out the information the best we can, and we'll continue to to support our surgeons, the membership, and the patients that they take care of at the very best of our ability. Thank you.